Imagine opening your medicine cabinet tomorrow morning.
Right. Just a typical start to the day.
Yeah, exactly. You reach for a small plastic bottle, pop the cap, and, take out a little pill. You swallow it down with a sip of water, just like you have every single day for the past, I don't know, 5 years.
Wow, 5 years. That's a long time to build a habit.
It really is. And you do this because a doctor you trust implicitly looked you in the eye after literally the scariest day of your life, the day you had a heart attack, and they told you this pill would keep your heart beating.
Right.
So this daily routine, it's your shield. It prevents a terrifying, life-altering myocardial infarction from ever happening again. I mean, you wouldn't dare skip a dose.
No, absolutely not. I
Yeah.
mean, the psychological weight of that tiny pill is just immense.
Oh, for sure.
When the stakes are literally life and death, we cling to our safety nets. That daily routine basically becomes a foundational part of how a patient views their own survival.
Which is why it feels almost jarring when the medical community suddenly taps you on the shoulder years later and asks, actually, do you still need to be taking that?
Yeah, it's a huge shift.
It is. And welcome to our deep dive. Today, we are pulling our insights from a really fascinating, paradigm-shifting clinical trial. It's titled Non-Inferiority of Beta Blocker Discontinuation Post-Myocardial Infarction.
It's a bit of a mouthful, but the concepts are incredible.
Totally. So our mission today is to explore a fundamental question in modern medicine, which is what happens when standard life-saving protocols might actually be outdated?
It really is the scientific method functioning at its absolute best.
Yeah.
Oh, definitely. We're looking at a process of continuously checking our own homework,
Yeah.
seeing if the rules we wrote decades ago still apply to the bodies we are treating today.
Okay, let's unpack this because we really need to understand the medical status quo before we look at why researchers want to disrupt it. For a very long time, the absolute gold standard of care has been to prescribe long-term beta blocker therapy after someone suffers a heart attack.
Right.
You survive the initial cardiac event, you're prescribed beta blockers, and that just becomes your new normal.
Well, we do need to narrow the focus a bit just to clarify exactly who this study is looking at.
Okay, good point.
Because this trial is not evaluating every single person who has ever had a heart attack. We are looking at a very specific subset of survivors, patients without left ventricular systolic dysfunction and without heart failure.
To put that in everyday terms, we are basically talking about people whose hearts, despite suffering an attack, are still pumping effectively on their own.
Precisely. The critical metric here is their left ventricular ejection fraction.
Which is what, exactly?
It's basically a measurement of how much blood the heart's main pumping chamber pushes out with each contraction.
Right, got it.
And for the patients in this study, that fraction is solid. It's at C40%.
So they're doing all right.
Yeah, I mean, their hearts have sustained an injury, obviously, but they are physically stable and doing the work of pumping blood efficiently.
Which brings up a massive question. If these people are stable, right, and they are taking their beta blockers, why even question the therapy?
It's a fair question.
Right. Like, why mess with a formula that is clearly keeping people alive? To answer that, we really need to talk about what a beta blocker actually does mechanically. We throw the term around, but how is it protecting the heart?
So beta blockers function by literally blocking the effects of the hormone epinephrine.
Which most people know as adrenaline.
Exactly. Adrenaline. When adrenaline binds to receptors in your heart, it tells the heart to beat faster and pump harder.
Which sounds like a bad idea if you just had a heart attack.
Oh, it's the absolute last thing you need.
Yeah.
If your heart has just suffered severe trauma from an infarction, it does not need to be overworked. So by blocking that adrenaline, the medication forces the heart to beat more slowly and with less force, and that lowers blood pressure and drastically reduces the heart's demand for oxygen while it heals.
Wow. Okay. It makes me think of putting a speed governor on a car engine right after it overheats and takes some damage.
Oh, that's a great way to look at it.
Yeah, like you install this device to force the engine to run slow and cool. You intentionally restrict its performance so it doesn't just tear itself apart while you figure out how to repair it.
What's fascinating here is that your engine analogy perfectly captures the tension researchers are currently observing.
How so?
Well, in the past, a heart attack caused massive permanent damage to the cardiac muscle. The quote-unquote engine was permanently compromised.
Right. The damage was done.
Yeah. So leaving that chemical speed governor on for the rest of the patient's life made total sense. The heart needed permanent protection from overworking.
Makes sense.
But the text points out that the necessity of this therapy is suddenly unclear because we have entered the era of contemporary coronary artery reperfusion and, modern secondary interventions.
Wait, reperfusion essentially means fixing the plumbing, correct?
It does, yes.
Mm-hmm.
It is the rapid restoration of blood flow.
Okay.
Today, if you have a heart attack, you are rushed to a hospital where doctors can immediately deploy interventions like balloon angioplasty or inserting stents to just prop open those blocked arteries.
And that changes everything.
Completely.
Mm.
We can clear the blockage and restore blood flow so quickly that the heart muscle often doesn't suffer the massive, irreversible tissue death it used to decades ago.
Wow. Extending the car analogy, modern mechanics are getting in there and completely rebuilding the radiator and the exhaust system the very same day the engine overheats.
Exactly.
The underlying problem is fixed and the engine heals remarkably well.
And if the engine is completely repaired, leaving that speed governor on for the rest of the car's life just means you are driving a healthy vehicle that inexplicably cannot go over 40 miles an hour.
That sounds incredibly frustrating.
It is. Because beta blockers, while historically life-saving, they still have side effects.
Right, it's not just a magic pill with zero consequences.
No, not at all. They can cause fatigue, weight gain, depression. They lower your blood pressure, sometimes way too much.
Oh, wow.
So if the modern plumbing fixes the heart so effectively that it no longer needs the protection of the beta blocker, then prescribing them for decades might just be an unnecessary burden.
But, I mean, medical science cannot just assume the plumbing fixed everything, right? You can't just tell thousands of heart attack survivors to throw their daily medication in the trash based on a hunch that modern stents have made beta blockers redundant.
No, absolutely not.
If you're going to remove a safety net, you really have to test it.
You have to test it rigorously, and the mechanics of how they designed this trial are incredibly revealing.
Let's get into that.
So this was set up as an open-label, randomized, non-inferiority trial. And it was conducted across 25 different medical centers in South Korea.
Okay, I want to push back on one specific element of that design, the term open label.
Sure.
Because when I read that, a little alarm bell went off. Open label means that there are no sugar pills being used here.
Right, no placebos.
The doctors knew who was continuing the medication, and the patients knew if they were in the group told to stop taking it. Doesn't that risk introducing a massive behavioral bias compared to a double-blind placebo study?
It's a really valid point.
Because if I am a patient and I know I just stopped taking my vital heart medication, I'm going to be terrified. I might stop exercising. I might be overly anxious about every little flutter in my chest, which, could skew the results.
It is a vital critique.
Yeah.
And honestly, researchers agonize over it. Knowing your assignment absolutely introduces the potential for psychological and behavioral shifts.
Oh, I do it.
You have to weigh that against the sheer logistics of a trial like this. Creating perfectly matched placebos for a drug that thousands of people have already been taking for over a year and managing that secret supply chain across 25 different hospitals, it just becomes logistically prohibitive.
I see. Plus, I guess if we think about what the researchers are actually measuring, behavioral bias can only skew things so far.
Exactly.
A heart attack is a physical, measurable event. You cannot placebo your way into an infarction, and anxiety alone won't create a massive cardiac block.
Right. The clinical endpoints they were measuring were hard, undeniable physiological events. So while open label isn't perfect, the physical data remains robust.
That makes sense.
But the truly brilliant part of this trial's architecture is the non-inferiority design.
Yes. Let's spend some time on non-inferiority because it totally reframes how we think about a medical breakthrough.
It really does.
The goal of this trial was not to prove that throwing away your beta blockers acts as a miracle cure.
Right. The researchers were not trying to prove that stopping the medication makes you healthier or gives you super strength.
Right, no superpowers here.
Sadly, no. They simply needed to prove that stopping the medication is not unacceptably worse than staying on it.
Show me this isn't a disaster. It is such a pragmatic way to approach patient care.
It is. Because if two paths lead to the exact same baseline of health, but one path requires taking a prescription drug every single day and dealing with its side effects.
The path with fewer drugs is inherently preferable.
Exactly. Non-inferiority is about establishing a very specific safety boundary. They needed mathematical proof that the path without drugs didn't veer off a cliff.
And they established a strict mathematical boundary for this. The trial's pre-specified non-inferiority margin was an upper limit of the 95% confidence interval for a hazard ratio of 1.4.
Yes.
Let's make sure we translate that for the listeners so the genius of this safety net is clear. How do we understand a hazard ratio of 1.4 in a real-world setting?
Let's break it down into risk. A hazard ratio is basically a way to compare the risk of an event happening in two different groups over time.
Okay.
If the hazard ratio is exactly 1 point E.O., the risk is perfectly equal.
Meaning the group taking the pill and the group stopping the pill are experiencing the exact same number of negative events.
Right. Now, a ratio below 1 means the group you are testing is experiencing fewer negative events. A ratio above 1 means they are experiencing more.
So by setting the limit at 1.4, they are acknowledging there might be a slight increase in risk if you stop the medication, but they are capping what is acceptable.
Exactly. They drew a very firm line in the sand. A hazard ratio of 1.4 implies a 40% relative increase in the risk of an event.
That sounds pretty significant.
It is a clear boundary.
Yeah.
The researchers decided, before the trial even began, that if stopping the medication increased the risk of another heart attack or death by more than that margin, the trial would fail.
Right.
They wanted to be 95% confident that the true risk would not cross that 1.4 threshold. If the data pushed past that line, it meant stopping the drug was simply too dangerous.
This raises an important question about how we define a win in medicine. Because sometimes a win is discovering a groundbreaking new vaccine. But sometimes a win is realizing we can achieve the exact same health outcomes while shedding an unnecessary chemical intervention. We can streamline care without sacrificing safety.
Which, of course, requires finding thousands of people willing to test that theory.
And considering the immense psychological weight of these medications we talked about earlier, I have a profound respect for the people who volunteered.
Me too. It's a huge leap of faith.
The trial randomized 2,540 patients in total. They split them right down the middle in a 1-to-1 ratio. 12,246 patients discontinued their beta blockers, and 12,294 continued their daily regimen.
And the timing of when these patients enter the trial is crucial.
How so?
Well, they had an average age of about 63. But the defining factor was that every single one of them had already been receiving beta blocker therapy for at least 1 year following their heart attack.
Why is that 1-year mark so critical to the science? Why not test people who had a heart attack, say, a month ago?
Because the first year after a myocardial infarction is the acute healing phase.
Oh, okay.
That is when the heart muscle is actively recovering, scar tissue is forming, and, honestly, the risk of a secondary event is exceptionally high.
Right. The heart is vulnerable.
Highly vulnerable. During that first year, the speed governor is absolutely necessary to protect that tissue. By waiting until the 1-year mark, the researchers ensured they were testing stable patients whose acute healing was totally complete.
Now, if you are looking at the demographics of this study, there is one specific data point regarding these participants that we have to note.
Yeah, it's quite noticeable.
Out of the 2,540 patients involved, only 12.8% were women.
That is a stark statistical imbalance.
It is. It's a pure scientific limitation that we always need to keep an eye on when analyzing clinical outcomes. Heart disease, its symptoms, and how the body responds to cardiac medications can present very differently across sexes.
Right.
Because the study population is nearly 87% male, we have to recognize that as a boundary on how broadly we can immediately apply these specific conclusions to the entire general population.
It is a necessary lens for viewing the data. You cannot universally generalize a finding if your test group is highly homogeneous.
Exactly.
But for the individuals who were represented, we really have to remember the context of their lives. These were stable individuals going to work, raising families, and trusting this little pill every single morning.
Right. It was their safety net.
Making the decision to join the discontinuation group meant consciously choosing to walk away from that perceived safety net.
So we have the motive, the advancements in modern plumbing making the old speed governors questionable.
Right.
We have the method, a non-inferiority trial with a strict mathematical safety net. And we have the brave, stable participants who were over a year out from their initial trauma.
It all comes down to the results.
Exactly. What happened when they finally removed the governor?
Well, the researchers followed these patients extensively. The median follow-up time was 3.1 years.
That's a good chunk of time.
It is. And the interquartile range, which essentially means the middle 50% of the participants, were tracked anywhere from 2.5 to 3.5 years.
Okay, so we have a very solid multi-year window to observe how their hearts behaved without the medication.
Yes. And during those 3 years, the researchers were tracking a very specific primary endpoint.
Right, they were looking for a composite, meaning any combination of 3 major events. death from any cause, a recurrent myocardial infarction, or being hospitalized for heart failure.
The undeniable, hard clinical events.
And the numbers that came back are incredibly compelling. I want to look at the group that stopped taking their medication first.
Okay, the discontinuation group.
Over the course of the observation period, 58 patients in the discontinuation group experienced a primary endpoint event.
And how did that compare to the group that kept taking their daily beta blocker?
In the continuation group, 74 patients experienced an event.
If we connect this to the bigger picture, you can immediately see the irony in that raw data. I mean, the researchers built this elaborate trial simply to prove that stopping the medication wasn't a complete disaster. Yet the raw number of negative events was actually lower in the group that stopped taking the pills.
We should probably break down how the study interprets those raw numbers because they utilize a metric called a 4-year Kaplan-Meier estimate.
Yes, that's important.
The estimate was 7.2% for the group that stopped versus 9.0% for the group that continued. What exactly is a Kaplan-Meier estimate doing with those 58 and 74 events?
So a Kaplan-Meier estimate is just a statistical tool used to predict the survival rate, or in this case, the event-free rate, over a specific period of time.
Because people leave the study.
Exactly. In clinical trials, patients drop out, they move away, or they just get lost to follow up at different times. The Kaplan-Meier curve takes all those uneven timelines and smooths them out to give us a reliable prediction.
That's really clever.
It is. So it is estimating that over 4 full years, about 7.2% of the people who stop the drug would have an event, compared to 9% of those who stay on it.
Now, we have to be careful not to jump to extreme conclusions here.
Right. We can't overstate it.
This data is not saying that stopping your heart medication magically prevents future heart attacks better than taking it.
Statistically speaking, no. The difference between 58 events and 74 events across thousands of people isn't large enough to definitively declare that stopping the medication is vastly superior.
Okay, so it's not a cure.
But it absolutely shatters the anxiety that stopping the medication would be dangerous. Let's look at the hazard ratio the trial produced. It came in at 0.80.
Wow. Which is well below the 1.0 mark of equal risk and miles away from their danger limit of 1.4.
Exactly. The 95% confidence interval for that ratio ranged from 0.57 to 1.13.
And since that interval overlaps with 1.0?
The scientific community considers the clinical outcomes between the two groups to be essentially equivalent.
Incredible.
But the most vital number for the researchers was the p-value for noninferiority, which came out to 0.001.
So, translating the heavy statistics, a p-value that tiny means the researchers are overwhelmingly confident in the results.
Unbelievably confident.
There's almost zero chance this was a fluke. Stopping the medication was undeniably not worse than continuing it.
It confirmed the hypothesis perfectly. For these specific stable patients, the beta blockers were no longer functioning as a necessary shield.
Right.
The modern interventions, the stents, the rapid reperfusion they received during their initial attack had already done the heavy lifting. The heart was healed, the plumbing was clear, and the daily beta blocker was just a redundant speed governor lingering in the background.
So, what does this all mean? If we pull all these threads together, the core takeaway for you, the listener, is beautifully clear.
It really is.
If you are a stable patient more than a year out from a heart attack, your heart is pumping well, and you do not have heart failure. Safely discontinuing your beta blockers is non-inferior to staying on them. You do not necessarily have to swallow that pill every morning for the rest of your life.
And, even if you are listening to this and you do not have a heart condition, this study is a phenomenal example of why we must continuously challenge our assumptions.
Oh, totally.
It proves that medical science, and really any robust field of knowledge, is a living, breathing process. The best science does not just invent new things. It actively audits the old things.
That's a great perspective.
It empowers you to look at the long-standing routines in your own life and ask why. Are we doing this because it is actually necessary today, or are we simply doing it out of habit because it was necessary 10 years ago?
We get so locked into the way it has always been done that we completely ignore the fact that our environment, our technology, and even our own bodies have evolved.
Exactly. We forget to update the rules.
This trial gave thousands of people the empirical data they needed to shed unnecessary weight, which leaves me with a lingering thought I want to pass on to you, the listener, to chew on long after this deep dive ends.
Okay, let's hear it.
We just saw definitive proof that modern acute interventions are making long-term beta blockers redundant for a massive group of heart patients. The old rules genuinely do not apply anymore. So it makes you wonder, What else is out there? If this foundational, decades-old pillar of cardiac care is silently becoming obsolete, what other daily therapies or ingrained protocols from decades past might modern technology be rendering completely unnecessary right this very second?
That is a fascinating question.
Are there other pills we swallow, other rigid restrictions we place on our bodies and our lives, not because we currently need them, but simply because we are over-medicating out of fear and habit? How many speed governors are we all still driving around with, entirely unaware that the engine underneath healed itself years ago?
Something to think about the next time you look inside your medicine cabinet.
Absolutely. That's our deep dive for today. Keep checking your homework. We will catch you on the next one.